Good morning. Always a pleasure to come to a State of the Reform event. This is my 6th, and oftentimes I wonder, how does Fair Health find its way, for example, from our offices in New York to this beautiful city of Honolulu, wearing a lei, and it's a very unique journey that got us here. And even though we're not Hawaiian residents in Fair Health, we do have Hawaiian data, and that I'm really thrilled to share it with you. So our unique journey, I still have not found another organization that was created in the same way that Fair Health was created. We were created a decade ago, as DJ mentioned, out of an investigation by the Office of the New York State Attorney General, who was looking into the health insurance information being used to adjudicate claims. It was determined that there was at least the appearance of a conflict of interest in that data. The matter never went to trial. It was settled, and it was agreed really unanimously that a new independent not-for-profit should be created that could bring transparency and integrity to health insurance information. Even though it was a New York investigation, it gave rise to a national remedy. We were tasked with a number of key mandates. One was to create a data repository that could be trusted by all, that was really informed by the best thinking of economists and statisticians in the way in which we audit and validate the claims, and to use that data to populate benchmarks, custom analytics, visualizations that really bring visibility into the healthcare system. We were then tasked with, as a 501c3 independent not-for-profit, supporting policymakers, academic researchers, state and federal officials, really noodle through the difficult questions that everyone was trying to understand and to advance reform. And what was considered the crown jewel of the settlement was the launching of a free consumer website to allow consumers unparalleled visibility into healthcare pricing and to elevate health insurance literacy for all with really clear consumer resources. We really sit right in the middle of the healthcare schoolyard, if you will, because we're unbiased, because of our neutrality, and by interacting with all, we learn about all of the pain points, the difficult questions, the interesting innovation underway, and that helps inform our work to make sure that we can support all individuals and organizations with data to help them advance their thinking. So what do we have? Right now, we are the largest private healthcare claims collection in the country. We have over 30 billion records that date back from 2002 to the present, and that is data from fully insured and self-insured plans. The data are organized into 493 different geographic regions to really give the heartbeat of the particular medical market. We have dental data as well. In the aggregate, it represents about 150 million covered lives. In addition, because of the richness of the commercial data and the security of our infrastructure, CMS has designated Fair Health a qualified entity. As a national QE, we've been entrusted with the entire collection of Medicare Parts A, B, and D. Medicare Advantage is housed in our separate commercial repository. Before we dive into the data regarding Hawaii, just to give you a better sense of how this data helps inform all the stakeholders around the country, many federal agencies come to Fair Health for a variety of different kinds of support. For example, the Bureau of Labor Statistics uses our data to create its monthly medical indices. CDC uses our data to understand different clinical corners in the healthcare market. For example, whether it's Lyme disease or neurology disorders. We've worked with the USDA and FDA on food allergies, for example. And we help inform different federal policymakers on data democratization and data transparency, as well as other issues. In addition, we've also helped a number of states work through workers' comp programs, auto liability fee schedules. We also play a very prominent role in the surprise billing debate that's underway on both the state and the federal level. We have been tasked with serving as a benchmark in New Mexico and Texas, New York, and Connecticut as the benchmark to support fair reimbursement when consumers have been subjected to surprise bills for out-of-network services. We also serve as a benchmark for emergency services, for example, in the California Healthcare Code. So the way I think of it, those billions of claims is this sort of huge ocean that is somewhat opaque when you look at it from the outside. Our role at Fair Health is really to bring visibility into that data. I think of it as either like going out on a glass-bottom boat to allow you to see into that water. Although in Hawaii, I think more fun with fins and a snorkel to go out. And it allows one to really understand what's really happening in this very unique, interdependent, and intricate ecosystem. So let's go to the data of Hawaii. Let me explain how some of these graphs should be read. So one of the things we're learning, and sometimes we feel like the canary in the coal mine, we see trends that are occurring sometimes before they're even being discussed publicly, is really the unbelievable migration going on right now into different venues of care. We're seeing tremendous changes in patient migratory patterns, where they're presenting for services. For example, the way in which they're moving away from some traditional venues to less traditional, whether it's retail clinics, telehealth, urgent care centers, and so forth. And we've been tracking that very closely at the state level as well as at the national level. So let's start with urgent care utilization. And the way this chart can be read is we isolated all claims where care was rendered in Hawaii at an urgent care center based on the flag on the claim that would designate that place of service. This is over this 10-year period. And then we plot those claims over that period to see what the trend lines are, whether they're going up or going down. We likewise juxtapose that to the national trend lines. And then to the left axis would show what percentage of those claims are comprised against total medical claim lines, whether in the state or in the nation. And as you can see, Hawaii really substantially outdistances the nation in terms of urgent care utilization, not only just in terms of the trend lines, but in terms of the percentage against total medical claim lines. And not surprising, what we learn when we look at the data for a particular state is that state's personality coming out through the data. Given the large number of vacationers that you have here, people traveling through who don't have access to their regular doctor, it's not surprising that people would lean on the urgent care centers here more than maybe in other jurisdictions. Here what we've done is we've looked at the top diagnoses in urgent care centers in Hawaii and juxtapose it with the nation. And as you could see, while there's some commonality, their ear infections and skin infections are pretty prominent in the Hawaiian listing as compared to the nation. Then we also look at age cohorts. And you can see here that the distribution in Hawaii is somewhat different than in the nation. You can see that there's a higher percentage in the 0 to 22 cohort as compared to the nation, as well as higher in the older cohort, 60 and older. Again, likely demonstrating that around the nation we see that 23 to 40 cohort, typically people who are in the workforce who are trying to find a convenient time and place to get their care in their normal setting. Here it's not surprising that you would see younger people going to an urgent care center who may be here on vacation, or likewise older people, retirees, and other vacationers. Again, because the 0 to 22 population stood out, what we do sometimes at Fair Health is we'll in effect snorkel on the surface of the water, and if there's something really interesting, we'll go down and scuba a bit more to find out a little bit more data about a particular data point. And here we really wanted to better understand what's happening in that 0 to 22 age cohort. And as you can see, it's not surprising that, again, ear infections, skin infections really dominate, which is not, again, surprising given the water sports and the skin and sun exposure that they would otherwise experience. Looking at the 23 to 40, again, not too dissimilar from the national distribution, except again, the persistent indication of the skin and ear infections, again, showing the outdoor climate. So if you go to the ASC map for ambulatory surgery centers, you could see that Hawaii ranks 41 in the country in terms of the number of ASCs. Now, when you look at it plotted against national trends, it is not too dissimilar from the nation, but the nation actually started at a higher point in terms of percentage of medical claim lines and ends up at a slightly higher point as well. But it's really interesting. You're going to see very different utilization in ASCs in Hawaii than we're seeing around the country. First of all, in terms of the age cohort, it's different than what we see in the nation. For the most part, we usually see in that 41 to 60 dominating in most states, really, except Hawaii, with few exceptions, several others. And that's because 41 to 60 at ASCs are typically going for colonoscopies and endoscopies, the type of thing that would be an outpatient procedure. It's interesting that the 60 and older in Hawaii dominates, but that will be explained in a moment. So when you look at the top 5 services that are being performed in Hawaii, you could see that cataract surgery dominates. So again, not surprising that it would be the over 60 because some of the contributing factors for a cataract would be age, diabetes, exposure to ultraviolet light. So it's really fascinating how Hawaii is unique in that regard. Emergency room usage in Hawaii. As you can see, Hawaii, the increase actually is less than the nation. However, the percentage of total claim lines is dramatically higher than what you see in the nation. Although Hawaii seems like it's really trying to reduce utilization in the ER and triage to other venues. It sounds like you have some really interesting, innovative programs underway and policies with respect to paramedics serving on the scene and really looking at that ER utilization closely. And you could see that there seems to be somewhat a bending of that curve. When you look at the top diagnoses in emergency room, what you see is a number of procedures or diagnoses that relate to the outdoor climate, activity, sun exposure, joint, tissue issues, sprain, breaks and fractures, head injury, injury to the body. So not surprising, again, reflecting the personality of this beautiful state. Here, when you look at the emergency room age cohort distribution, again, higher in the 60 and older. And we looked at that a bit more closely to understand why. The 3 top diagnoses associated with that presentation at an ER involves chest pain, fainting, shortness of breath. Again, might be associated with people on vacation, indulging in things maybe that may be new or unfamiliar to them, or exerting themselves in ways that they don't typically do. Now what we did was we took all the top places of service and compared what that distribution is in Hawaii as compared to the nation as a whole. As you could see, in terms of both urgent care and ER utilization, it is higher in Hawaii compared to the country as a whole. The other thing that's notably absent in the Hawaiian pie chart, and we did not juxtapose it in the national just to keep it aligned with the same categories, are retail clinics and telehealth. The data for retail clinics and telehealth are much lower in Hawaii than we're seeing around the country. Both of those are on the rise. So the top 10 diagnoses in Hawaii, again, this is all venues. Again, not surprising what we're seeing. Again, very much geared toward those things that would happen from activity, joint soft tissue issues, again, injury to the body, head injury, sprain, breaks, and fractures, and so forth, as well as the eye infections. Top 10 procedures in Hawaii versus the nation. This is really interesting. So the top 5, as you can see, the first, third, and fifth represent E&M visits, evaluation and management visits. What's notable is the procedure to the right reflects a new patient visit. So you can see, compared to the country, Hawaii is much higher for new patient visits. Again, not surprising, because if you're presenting at an urgent care clinic, you're on vacation, you don't typically live here, you would be billed as a new patient. So it shows the nature of people coming in and out of the Hawaiian healthcare system. The other two that are most common are also not surprising, given when you see what are the most common diagnoses, which involve injury to the body or joint soft tissue issues. These two represent physical therapy procedures. Okay, so what's notable on this slide is that there's one line, and that's for the nation. So you could see there's been over a 1,300% increase in the nation over this period of time in the increase in telehealth claims. Right now, we're not plotting Hawaii because it was really insufficient volume to reflect what that juxtaposition would be. But I understand underway in Hawaii are laws now to really promote the adoption and the proliferation of telehealth and to evaluate it more closely and to create more parity between reimbursement in a telehealth setting versus in-person service. But I thought it would be helpful for you to see nationally what we're seeing, how states are taking advantage of telehealth. What you'll see typically, not only just in the aggregate nationally, but when you go into each state, you'll see mental health services really dominating. And what we've learned too is that reimbursement just drives a lot of what you see in utilization. And when we juxtapose reimbursement for a telehealth session versus an in-person session, the delta between those two is very small compared to some other types of services where the delta would be wider. And so I think what you're seeing is the willingness of mental health providers to participate in a telehealth network to render that type of service and really filling a void in a dearth of providers available to support these mental health needs. What we're also seeing, if we were to go down more to, say, service 5 through 10 or 6 through 10 in telehealth, what's interesting, what's coming up more and more are chronic conditions. Really, people are turning to telehealth routinely to manage their chronic conditions. Top behavioral diagnoses in Hawaii, somewhat different. While the top 5 represent the same categories that are in the national chart, you could see what dominates in Hawaii are the adjustment disorders. And that's more episodic as opposed to it being more of a chronic behavioral need. And there may be issues that occurred in 2018, whether it's environmental disasters or the false alarm that you all experienced in terms of potentially being under attack, or other kinds of life issues that would give rise to that prominent place on this chart. Let's look at behavioral health usage by age. So again, you could see that it is unique in Hawaii to have it being dominated in the 0 to 22 age group, whereas the 23 to 40 is the more prominent age group that is seeking out these services. And when we look at those top diagnoses in the 0 to 22 age group, what's interesting again, you see adjustment disorder really dramatically different than the country. You also see the phobic activity disorders. And what's interesting is bipolar disorder and others we're seeing at a much larger percentage than the nation. Provider specialties is always interesting to see what type of providers are servicing different kinds of procedures, because you may be able to, get behavioral health services, for example, from a primary care doctor, and it varies dramatically depending on the jurisdiction. So we thought, let's isolate evaluation and management services, basic office visits, and see what the differences are between Hawaii and the nation. And as you could see that in those two categories to the left, multi-specialty practices and group practices, Hawaii very much outdistances the nation when you compare, but yet when you go to nurse practitioners, you could see that it is dramatically different than the nation in terms of that specialty participating in primary care. Here, just wanted to show a little bit about varying reimbursement models. We look at both utilization, we look at treatment protocols, we also look at pricing, both from a billed charge perspective as well as an allowed amount perspective. And as you can see here, we are juxtaposing billed charges at the 80th percentile together with the allowed amount, the negotiated amount at the 80th percentile compared to CMS. And this is for a common procedure in an emergency room, stitches. And you could see here that Hawaii tracks lower than the nation in both the billed and the allowed 80th percentile, but is higher than the nation in terms of the CMS rate. That changes when you start looking at a moderate severity ER visit. You could see that Hawaii outdistances the nation, both in terms of billed charges as well as the allowed amount. And interesting, CMS reimbursement for that type of visit in Hawaii is practically the highest in the nation, even in Alaska, where there's only $87 associated with that visit. Here we just thought we juxtapose ambulatory surgery center reimbursement to outpatient billed charges. And what's interesting here, Hawaii is unique. For these services, the delta is much smaller in Hawaii between the outpatient billed and the allowed amount. Yet when you go to the allowed negotiated amount, you could see that this is what we would typically see in terms of a distribution between what's actually negotiated as opposed to what's actually billed. And here we're looking at the difference between office and urgent care within Hawaii, and then comparing both of those to the nation. So you could see what the hierarchy is between the median bill charge, for example, here in Hawaii, slightly higher for the urgent care, whereas it's much closer on the national side. And finally, we have done a lot of work with respect to the opioid crisis in the country. While we give our data out to researchers to do their own work, there are times when we feel we are privileged to have a data collection that could shed light on a very important policy issue. So what we did a series of white papers, all available on our website at no charge. The last one took all 50 states and looked at what were the top 5 procedures rendered in a state with respect to opioid abuse and dependence, and what were the top 5 most expensive services rendered. And what we saw was a really dramatic tapestry of difference between the different states, almost as though one state may not be looking over the fence at another to see what's being rendered. Here we're not going to expose you to all 50. We just took Arizona and California to see how Hawaii compares. Where the colors are the same, it means that there's commonality between the services being rendered. Where it's white, it means that there's no comparison or like procedure in the other state. And as you can see, there are 3 that compare in terms of office visits with Arizona, but yet behavioral health service here, the outpatient, is unique to Hawaii, and then you can see California is pretty much going on down its own path. What's really interesting here, and I don't know if there's another state we've encountered like this, typically when we look at the highest cost, it's usually associated with drug testing in connection with the treatment for opioid abuse and dependence. What's fascinating in Hawaii, that all of your services in the most costly categories are all therapeutic. And that may very well be a positive in the sense that there's some concerns about drug testing being too frequent, but here there seems to be a genuine focus on therapeutic settings. And not only do these different approaches have clinical implications in the outcome of treatment, they obviously have very different financial implications. So what we've done is just take the top 3 most frequent, the most highly utilized codes, and looking at it from the allowed amount differences to see what the implications are of what's typically negotiated for these services, and you can see how there's a tremendous variation in what the financial burdens are being shouldered by the state. Likewise, here are the 3 most expensive services that have been isolated by state. Again, you can begin to see the variation that's really unfolding in the data. Thank you very much.
I'm trying to find a thread through all that data. You know, like I'm trying to find some commonality. I get a little bit about the tourists coming and being overly exertive. But even that, there was some that makes a lot of sense, but there's some subtleties in there that I'm not sure apply in the same way. Do you see a thread that kind of combines all this stuff? I mean, is that the thread really, is the tourist piece?
Well, I think it's not just the tourism. I think it's also the environment, the client, the topography. I think just the unique characteristics of the state that are giving rise to some of the diagnoses presenting, whether it's impetigo or sunburn or water on the ear, things that not just tourists would experience. Mm-hmm. I think it also raises some interesting questions, and I know we had the privilege of the dinner last night to talk about the particular challenges of Hawaii. I found it fascinating looking at the distribution of the specialties rendering primary care and seeing the low proportion of nurse practitioners and even the lower proportion also of physician assistants. It seems like there are some real opportunities here that would allow for training and educational programs to integrate those types of practices in, particularly if there are underserved areas. Mm-hmm. I think one of the challenges too, when you look at urgent care settings, and this is not just unique to Hawaii because urgent care centers are becoming more popular overall, is the care management and coordination and looping back to other providers associated with that patient to make sure there's not duplication of services, to make sure there's follow-up, to really make sure there's appropriate coordination to lead to better outcomes. The convenience is wonderful and people appreciate that, but there should be a way to make sure that it gets integrated, whether through electronic records or other kinds of affiliations between providers.
So Hawaii's a low-cost state when we look at state spend per capita basis. Is it accurate if I sum up some of this to say that, generally speaking, the most commonly applied codes are relatively low-cost codes? Generally speaking, they are lower cost codes in absolute terms, but also relative to other states, and that the more you get into complex medical issues in an inpatient setting, that those costs are higher than in other states. Is that all accurate?
Yeah, no, I think that that's a correct characterization. I mean, one of the things that the data show, and there are real opportunities in terms of public health and education and training and so forth, is really attention to that 0 to 22-year-old cohort. Looking at some of those behavioral health diagnoses, there may be ways to integrate into sort of questionnaires, intake documents and all, or just conversations to really try to probe to see to what extent this patient may be in need and may need to be triaged to some other service. But I think that's right. I think the lower cost services like PT are quite prominent in regular office visits.
And to clarify again, this is commercial, some self-funded, Medicare, generally speaking, not Medicaid data.
Correct. So what was shown here is mainly just from our commercial, which includes Medicare Advantage. The Medicare 65 and older was not even reflected in this. So you can imagine what we were showing in terms of over 60 still being the dominant age cohort with respect to some of those services would even be higher if we were to introduce fee-for-service Medicare to this. This does not include Medicaid.
Yeah. Do you want to sit? I like standing.
I'm fine
That's
standing.
working.
I have a standing desk. This is great. I feel like I'm at work.
I want to make sure we have some time for some of your questions. And Rita, we've got a gentleman with his hand up right here. So, sir, tell us your name and organization and then have at it.
Dr. Stephen Kimmel, I'm a psychiatrist working at Queens. And you're missing a major factor influencing your data, which is we're undergoing a rapid shift from 75% of care being delivered in small independent practices that is declining rapidly and shifting to either no care or hospital-based care. We lost 91 doctors to retirement last year, 4 died, 152 left the state, and 123 reduced their hours, and we're only training 75 new doctors a year. So we're losing independent doctors very rapidly, and that may influence your urgent care statistics, your ER statistics, and what mix of codes get used.
I think your comment is very accurate, and it's not just true to Hawaii. In terms of the number of independent practices that are closing down or are being absorbed by a hospital system or consolidation, so that is true. That would not necessarily impact the diagnoses or the procedures, but in terms of place of service, it would certainly impact the site of service. You're correct that that's actually a nationwide trend.
Aloha, Liz Tam, School of Medicine. I have a quick question. That's a great hypothesis about whether that some of this is visitor driven, but are you able to see what proportion for different diagnoses are coming from non-Hawaii zip codes? Can you bear out that hypothesis?
So the way in which our data is presented, it's based on the rendering zip code or in the rendering area where care is provided. We do not have the enrollment data to be able to, other than with our Medicare data, to be able to say where someone lives. However, we do have imputation formulas and methodologies that if we can look longitudinally at individual patients to see if the majority of their care is being, for example, in Connecticut, and they had this one ER visit in Hawaii, there are ways in which we are able to impute a residential area to a patient and have done that on behalf of particular studies. We didn't do this in connection with the Hawaiian data, but we could.
I noticed the percentage of primary care mid-level practitioners is much lower than the national average in Hawaii. Why do you think that is? Do you think that's a regulatory problem?
I think it's a what problem?
Regulatory.
I think there may be multiple explanations for that. One is it may be the billing practices in this community. We see in some areas the nurse practitioner might bill under the ID, the MPI of the physician, and that may be true of the physician assistant as well. It's not true across the board, which is why you see that difference nationally to Hawaii. Other areas are not billing that way. So that may be one explanation. And one, it just may be a workforce issue. And one of the things that's really been exciting and interesting about the work that we do, one, we love to hand the baton to others. We'll find one data point, and then people can run with it and ask deeper questions, or sometimes we do as well. So it would be interesting to look at the billing practices here to see if that's one explanation for that difference.
Other questions? And we're getting short on time. And I know, Robin, that the question of ethnicity is probably not necessarily apparent in the data that you get. But we have Hawaii is such a ethnically diverse community, and the types of care vary in many cases and instances based on culture and history and community. How might we learn more about how some of this data applies to different communities within Hawaii? Are there organizations that might reach out to you or work with you to get a handle on this at a community level?
Yes, we are always happy to collaborate with other organizations and to create data cuts or do analytics that could bring greater visibility. We don't have ethnicity, but we do have age and gender, and that's often interesting to see the different results based on age and gender. But yes, we're always happy to collaborate and to try to bring greater visibility into the data.
Great. Well, Robin, thank you for coming all the way from New York to be here with us today. I really appreciate it. Let's give her a round of applause.